Very good afternoon to one and all. Thank you so much for this opportunity. Can I have my slides on, please? Yeah, so no financial interest in any of the products. So today as ophthalmologists, we want to give more and more better vision at all distances to our patients, but we need to remember that the challenges are not only just a good surgery and good counseling, but a good patient selection and the perfect IOL selection also. So in our center, we make it up a point that to do biometry on a virgin cornea, even before dilatation or applanation, obviously, look at ocular surface, topography, OCT, pupillometry, and angle alpha before the surgery is done. So if we ask what is the threshold for deciding whether a patient needs to use a toric or not. So what we usually do is put the K1, K2 on the Barrett toric calculator, and if it shows a toric, you go in for a toric. So it's not just like 1 diopter or 0.75 diopters, but remember that there is no ideal multifocal IOL. So these are all IOLs that give us a different kind of vision at different distances. So which IOL is best for my patient? That is the biggest question. For that, you need to communicate with the patient regarding what is his lifestyle choices, what is the distance that he wants, whether he desires spectacle independence, and then decide which is the functionally best IOL. So this is basically a slide where we decide which lens suits the patient the best. Now for your trifocal IOLs, you need a patient who has no ocular comorbidities, doesn't do a lot of night driving, and is wishing for spectacle independence. So here we are presenting the fine vision lens, which is a double C loop lens, which has ridges on the surface of the haptics. It has a central zone, which is 1.16 millimeters. The material that is used is a GFY hydrophobic acrylic material, which is glistening free, and it's a biconvex aspheric toric available in torics. The near addition is 3.5 diopters and the intermediate is 1.75 diopters. So now let's look at how it actually works. So it gives us excellent distance, intermediate as well as near vision. So what is different about this lens? It has a copodized diffractive technology. So copodized is a combination of two words. One is convolution and the second is apodization. So what do we mean by this? When you look at apodization, it means that the peaks go on decreasing from the center to the periphery. And that is why it reduces the impact of the defocused near image on the distance image. So it helps to reduce the amount of dysphotopsia. And the convolution means that the peaks are smoothened out, so that also reduces dysphotopsia. So this is a patient who was a NS2 grade cataract and who wanted flax. So the flax has been done. Relatively soft cataract, so we tumble the nucleus into the anterior chamber and phacoemulsification is done. Bimanual irrigation and aspiration to remove the cortex, and you can do a BSS wash onto the posterior surface to remove any stuck cortex. So this is the lens that you pick up from the case and then you implant it into the cartridge, very gently seeing that the optic edge and both the haptics on each side are properly placed, and push the plunger to see that it moves smoothly. So very smoothly it goes in through a 2.2 millimeter incision, and you have to carefully see that both the haptics go into the capsular bag, the optic opens up, and with a gentle tap, the trailing two haptics also go into the capsular bag. So here you can see that there is a notch, which means that one of the haptics is outside. So it very nicely with the left hand, you can use a Sinskey hook and you can gently tuck it underneath the capsular margin. So you can see the diffractive rings on the surface, and because the length is almost 11.4 millimeters, it's extremely stable and hardly any decentration. So this was the convolution that we were talking about. It smoothens the peaks and that helps to reduce the visual disturbances or starbursts at night. If you look at the point spread function data, it's almost similar to that of an ADOF IOL. So that means the dysphotopsia is really less, something which is not really common in trifocal diffractive IOLs. If you look at the distribution for near is a little more than that for intermediate. So it really gives you good near vision. So today we have a lot of ADOFs available, but the problem with them is they always need a reader. So whenever a patient demands spectacle independence, you need to provide them a lens that actually works for near and without the greater compromise of dysphotopsia. So this is the near vision refractive results, the distance corrected near visual acuity, almost 93% patients are 20/25 or better. As regards the optical clarity, it is a UV blocker with a blue light filtering with a glistening free. That means year after year your patient continues to have good optical clarity. Again, what is important is a very low PCO rate, because when multifocal IOL patients, you know that even a very early PCO can suddenly cause a drop in the contrast sensitivity, but this lens actually has a square edge barrier with a posterior haptic angulation, and this technology helps to act as a barrier against the PCO. Important part, if you're using a toric trifocal, we do not want any rotation. So with this double C loop, there is a 70% greater contact angle, which means that the greater rotational stability helps to keep the astigmatism under control, and that gives us a better astigmatic correction. So another very good point about this is with a C loop, you cannot rotate it anti-clockwise, whereas with this, because it is a double C loop, you can rotate it both clockwise as well as anti-clockwise. So it's very easy to use these lenses. Whenever you are doing counseling for these patients, you need to pick up patients with realistic expectations, explain to them about the possibility of glare and halos, but we also remember that neuroadaptation can really help us to overcome this challenge. Also, we take a special consent for these patients and tell them that they might need to use glasses for some activities, especially reading in dim light, so that post-operatively the patient doesn't get perturbed about it. So whenever the patient is not satisfied with what he has got, remember that sometimes you have to have a proper checking up of the patient to look for whether the ocular surface is good or not, whether the macula is good or not. So for all these patients, an excellent preoperative workup is important. So with these premium trifocal IOLs, which are easy to implant, safe, efficient, reliable, and this was the first trifocal lens, and with years of trusted technology, consistency and reproducibility, I think today we can give better visual outcomes and have happy surgeons and happy patients. So promising newer technologies give us better visual outcomes and happier patients. Thank you so much for your kind attention.
Wonderful talk, Dr. Anagha. The few things I want to ask you is, how is the PCO effect with this kind of lens design, PCO?
So as I mentioned, the PCO effect is really very less because of multiple reasons. One is the material. Secondly, it has a linola sandwich kind of technology, so it is an higher adhesiveness to the posterior capsule. It has a square edge and a posterior angulation, so it actually has a very, very minimal PCO rate and a hydrophobic material.
Has it been compared with any lens of the Rainer design, which also has the sharp posterior edge and then,
Yes, Rainer is a hydrophilic material, whereas this is a hydrophobic, which obviously has a lower PCO rate.
Another thing was, if you have to place a CTR in the capsular bag, does the lens get tilted because there are 4 points of fixation?
Not at all,
all of them are not lying
when
on the
we
CTR.
put in a CTR, the entire capsular bag gets stretched.
Yeah.
So it's as good as a normal.
See, one of the points of the haptics can be resting on the CTR. Another area can be. Another
but they are very gentle.
In the capsular fornix. So there can be some amount of, theoretically, some tilt can be expected.
No, sir, because the CTR is a very thin profile, and these haptics are very gentle, and then they just lie against the fornix of the capsular bag. So that shouldn't be a problem.
Any questions for her? So thanks a lot, Dr. Anagha.
Thank you.